Specifically looking at the hormone receptor negative group, their PCR rate was above 80%. So that's really remarkable PCR rates that we've seen.
So Ruta, with regards to DB11, obviously we've got the PCR rates. Maybe you can review those real quickly, but also we don't have a lot of other data, right? Like we don't have EFS and OS, and those are important too.
Right, so we definitely saw an increase in PCR rates. There was a delta of about 11% for the patients who received the T-DXd followed by THP. And specifically looking at the hormone receptor negative group, their PCR rate was above 80%. So that's really remarkable PCR rates that we've seen.
Here we're talking about just 4 cycles of this new drug, exciting drug. Obviously we're getting really compelling PCR rates, better than what we expect even with the standard of care. And then on the back end, we don't have the long-term outcomes, right? The event-free survival outcomes, the overall survival outcomes. So there's a little bit more speculation here about what that'll look like. Putting all of that aside, here we are in the United States. You're in clinic, you have a patient. High risk, do you roll the dice and kind of go with the DB05 sort of backbone this is what I could do? Or are you so motivated by these PCR rates to start thinking about incorporating these strategies now, today?
I think, that's really the question we're going to face in clinical practice, and it's going to be a very tough one. I mean, on the one hand, the PCR rate with the T-DXd followed by THP was so impressive. And if you get a path CR, then these patients don't need any ADC in the adjuvant setting. Right. And that's wonderful. We know that just getting trastuzumab or the HP combination in the adjuvant setting is definitely much easier for these patients. So, I think a lot of us will be tempted to kind of go for it at the beginning. I think really the question's going to come up if we do that and they still have residual disease, then how comfortable do we feel giving T-DXd in the adjuvant setting with residual disease because that's not how DB05 was done.
Correct. Well, and then the other scenario that I've heard just anecdotally around talking to folks is they say this: I wish they gave the T-DXd first, right? And I get that sentiment, but is there a world or a scenario where you think, I'm going to give T-DXd first, see what happens, and then give AC? I mean, what would you do in that scenario? Like, you can clinically monitor these patients. You can do an MRI and see how the breast disease is being modified by that first agent. But
I think in an ideal world, that would be a great way to do it. I think what was really appealing to me about this trial is that it was 4 cycles of T-DXd, as opposed to, if you're asking me to choose between one and the other one having 14 cycles, we know the toxicity are higher. If you could get a path CR with, a DB11 approach with 4 cycles of T-DXd, I think that's a huge advantage for your patient.
Well, and then it goes unsaid still, but if we're worried about neoadjuvant therapy, residual disease, and brain metastases, then here's another opportunity to sort of nip that issue in the bud if you give the T-DXd earlier as well. So, Yeah, and then in terms of, you brought it up a little bit, I'm assuming we're still going to have to face the same kind of in-the-moment toxicities like nausea and growth factor support, et cetera. Did you see any safety signals that worried you with the neoadjuvant approach? No,
and actually what I thought was very interesting was that the rate of ILD was very low, I think about 5%, and relatively similar actually for the AC-THP arm. And we don't really think about ILD for AC-THP, and I wonder if it's just because it was being monitored.
You're looking for it.
Yeah. So how much of that was, are we just missing because it's not clinically significant and we're not monitoring those patients?
Yeah, and in my experience when I've been giving T-DXd, the ILD, it's rare for me to see ILD within 4 cycles anyway. So you may just be obviating that concern even altogether, which should make life simpler for a lot of people as well.
Agree, especially when we're talking about the number of scans we need to do to monitor for it, for these patients. I think it would be really nice to have a 4 cycle regimen where it's very effective.